Hello, this is Ed Kim,
And I'm Gurpreet Dhaliwal.
and we're going to talk about presenting patients on the surgical rotation. So the goals will be to try to highlight the differences between the surgical and medical mindset and how that translates into how we communicate to each other about patients, and then also to focus on the differences between the intervention mindset versus the diagnostic mindset. And hopefully, after listening to this podcast or looking at this video podcast, you'll be able to develop presentation styles that are more appropriate for each specific context.
In talking about the medicine presentation, I'd emphasize that medicine, like surgery, has a procedure, but in medicine, our most important procedure that we do is thinking. And as a student, what we're really asking you to do is put your thinking on display and answer the question, what is wrong with this patient? It might be when they're admitted or when you're seeing them the next day. But in each presentation, you're explaining what is wrong with the patient and why. And we have a very orderly way in which we present the evidence. So we start with a long sequence of data, but in the end, we're really listening to say, how convincingly can you tell us what the main problems are and what are the most likely, somewhat likely, and unlikely possibilities to solve this patient's problem? And we look for the evidence that you give for and against. And that really is the crux of the internal medicine presentation.
Now, for the surgeons, we have a much more procedurally based mindset, meaning we want to know whether we need to do something for the patient. So a lot of our patients are acutely ill. So the first and foremost question is, does the patient need an operation? And whether the patient is acutely sick and needs it urgently, and whether the patient can tolerate an operation. And then more sophisticated question would be what the best approach is and what other options are, including a non-operative one. So we are also concerned with diagnosis, obviously, but we don't look at it from trying to figure out from a set of symptoms or data to come to a diagnosis. Where we actually look at it more from, this is what we think the diagnosis is all the data that is all the data that are present support that diagnosis, or is there something that we need to worry about that may indicate that it isn't the correct diagnosis? So it's a little bit of a backward, or I wouldn't call it backward, but it's coming from a different direction.
And I would say this is actually really important and interesting for me to see. Sometimes students, after they finish with me on medicine, say, well, what's going to be different about the presentation on surgery? And I'd say, oh, just do it faster. And what this, I think, points out is that, no, that's not exactly right. Conciseness is emphasized, but there's actually a completely different set of questions that the surgeon is asking. And until Dr. Kim and I looked over this, I actually didn't have this framework. So I hope it's helpful for students, too.
So here's two different ways to look at presentations. I think these are probably reflective of most of our colleagues.
Agreed. And I would say on the medicine one, that's the standard sequence. I always emphasize with students, we also do want you to be concise. We oftentimes permit up to 7 or even 10 minutes to present, but that you are giving an executive summary of what you've written down in your admission notes. So we do follow that sequence, but there's a lot of liberty to truncate sections. And I would say in general, we really like the HPI and we really like the assessment and plan. And that's because the HPI is a story, so the human brain likes to hear a story, and the final section is solving a problem, and the human brain likes to hear about problems and solutions. But the big chunk in the middle is a lot of data. And so that's where I encourage people to start editing and being concise to focus on just what's relevant for their final pitch at the end. But we still do give adequate time to go through that sequence.
And I think on the theme of stories, I think one way to look at this is a good medical presentation seems to be one like a good campfire story, you would say?
Yeah,
where you don't give it all away.
I think that's a fair
right?
statement, right.
Right.
When people put the ED events at the end of the HPI, which is a growing trend, or sometimes even give the diagnosis, the listener is almost sitting there and they're like, why am I going to sit through the rest of this? So yeah, we really do want that campfire approach where you're building up to the end.
Right. Whereas for us, it's actually the other way around. For us, it's more like a legal brief. Sorry, we're more more boring in that sense. We want to know what the diagnosis is, if the diagnosis has already been established, and we want the facts to support that diagnosis. So instead of, we want the punchline early instead of trying to lead people on. I think that's one of the things that we find a little bit annoying or that we don't like is lead-ons or these false
blind alleys and other
Yeah,
things.
exactly.
Yeah.
Yeah. So those are loose ends for us that we think has some significance because you mentioned it, and then for it not to have significance in the end, is something
And
that we don't
we're okay.
appreciate.
Like if you said like the person has a pet parakeet or something, and in the end you might mention hypersensitivity to pneumonitis, but you're not going to go there. We're okay with that. We know you're still going to sell us on pneumonia, but we're glad that you found out they also have a parakeet.
So for us, if you look at the different parts of the presentation, so instead of the chief complaint, history of present illness, past medical, we actually want you to just create a story in the HPI that contains all the relevant information that leads to the diagnosis and that points to what is likely to be the intervention. And everything else, meaning the past medical, the medications, that can be, in essence, an appendix to make sure we haven't missed anything. So in the history of present illness, you should put past medical history that's significant. So if the patient has really bad CHF, you should put that in the HPI as part of the history of present illness. Somebody who has bowel obstruction, who has a very bad CHF with EF of 20, we need to know that early, not in the list, because that's where we have the information. That's what our story is about. So even medications like Plavix, we want to know that in the front. And so that includes physical examination, specific labs, and studies. Even those results should not come at the end. It should come at the beginning, because you can't really tell, in our opinion, at least for our purposes, we can't really get a good sense of the certainty of the diagnosis and what the intervention is going to be without having all that information in the one first spot.
And Dr. Kim, can I clarify then? So when that appendix, you mean like someone may say by the time they're getting to the end of the first paragraph of their presentation that the diagnosis is diverticulitis, and they might have mentioned that the person has CAD, and they might have mentioned that the person's on Coumadin, and then told you about a CT scan and said there's diverticulitis. But then should they run through all those other sections that follow again and talk about more of the medicines they're on in the appendix?
Yeah, so I think you can, in the appendix, you can go over the things that you have stated already and then all the other stuff that's not as relevant.
Okay.
So it requires a little bit more synthesis and interpretation.
Early on.
Yeah, exactly, early on. What is important, so you have to put it forward.
Got it. Okay.
So I think this graph or this model is actually an interesting way to think about the differences between our two disciplines and how it impacts how we tell the story.
And I really like this. When I looked at it, I realized that medicine is very far on the left. I noticed you made the left blue and the right red, and I assume that's not political. But I think what we do in medicine is mostly new diagnoses. Occasionally we have people who are admitted to medicine. They're admitted for a cath or they're admitted for chemotherapy. And to some degree, then you do get a bit of license to give the more procedural or surgically oriented presentation that Dr. Kim presented. But I do think most of the time on the medicine clerkship, you're on that far left. And so you have to be more all-encompassing and selling your listener on what the patient has first, and then really plan comes second.
Yeah, so in surgery, we do still see patients who have issues that are more diagnostic. So for us, I think one of the first things on rotation, when you see a patient on our rotation in the clinic or in the emergency room, is to try to figure out where they are in this process. Are they coming in for a symptom and we're trying to figure it out, or do they already have that's something or their diagnosis confirmed with a very reliable study? So that is the first step for us to tell you in terms of what you need to do. So here, let's look at.
I just want to jump in on that. I would say that you have the same license on medicine. If someone is a very, very treatment-oriented admission, by all means check with your senior and say, do I need to go through a differential diagnosis if this person is admitted for chemotherapy, or may I just present that as a known problem and move on? And oftentimes they'll tell you to take that approach.
So here's an example. So it is a patient with acute appendicitis. And so if you just see this patient early in the evaluation process, right, let's say in clinic.
I think if you see this, right, this person right now has There's even exam you might have completed in the clinic, and maybe some basic labs are going to be coming in the clinic or the ER, but nothing definitive has happened. The expectation is that you will tell the story, and again, HPI is a big part of it. And I would say, even looking ahead, like in the end, if this person has appendicitis and somehow they're being admitted to medicine because they're elderly or they were getting antibiotic strategy, and the CT scan was definitive, we would still want you to construct the complete story. Take us all the way down to the differential diagnosis of right lower quadrant pain, and entertain possibilities that the CT scan is one part of the story and not everything that's going on.
So, and in this case, this is a presentation for somebody later in the process. So someone who is getting called for a surgeon to see them. So basically, they've already had the CAT scan. So when I hear about somebody with acute appendicitis, first thing in my mind is, do they need an operation? Not all people with appendicitis need an operation, especially at the VA. They can be very sick and may not be a good surgical candidate. And also with appendicitis, when there's a phlegmon or an abscess, they should not go to the operating room. So this is the information that I would like to know. And so I am not as interested in whether they had periumbilical pain that migrated, because the CAT scan shows an inflamed appendix. There is they have leukocytosis and they have tenderness. So the diagnosis is already set. So the story about their symptoms is, I think, important in the sense of just telling a story, because you like you said,
captivate your audience.
Exactly.
You have to give some preamble.
Definitely.
To the punchline.
But that's not the most important part. The most important part is for you to be able to give us an idea of whether the patient is a surgical candidate and what kind of a procedure or an operation would be appropriate, or not having an operation would be appropriate. So I think
that's an example of the narrative you might want to hear then.
Right, exactly. So that's where the HPI tells us everything about the story, and then we get the appendix after on. There's no, oh, this guy has right lower quadrant pain, and let's try to figure out what it is. And I think one of the important thing is really that these activities need to be authentic, meaning, if we artificially try to create this out of a case like this, I think most people would not, at least most surgeons, probably wouldn't have the patience to allow you to finish your presentation that you probably worked really hard on.
True, and that's the end goal. And I think that I might say this to all the students who are listening, that probably on both these rotations, your write-up, what you write, will be quite similar. The H&P that you write for this patient, whether they're going to be on medicine or surgery, or kind of whether they're early or late in the evaluation process, might be very similar. But the point we make on both rotations is that the oral presentation is an executive summary of your more lengthy written note. And the points we tried to make here is where this person is on the diagnosis versus therapeutic spectrum, and to some degree, what your audience is listening for are the things that should guide how you summarize what you wrote in your more thorough note.
Great. Thank you so much for listening.
Thank you.
And good luck on your rotation.